Welcome to the Reverse Mullet Healthcare Podcast. We are live at the ACLM conference, the American College of Lifestyle Medicine.
He did it. Yeah, there you go. You got
2024, Orlando, Florida. I'm Justin Politi.
Dave Pavlik.
I'm Alan Brown.
I'm Justin Politi. I'm Mullet Man. But we're here with Shawn Martin, and I'm super excited because I think your organization is integral to what's happening today. You know, we had Susan Benegas on yesterday, and she used the term catalyst for transformation.
Yeah.
And you have been in this uphill battle with family practice for the AFP of how do you enable family practice, primary care to fulfill what it's capable of fulfilling, right? And it's such a challenge with the RVU model and a fee-for-service model and just what we've been up against. And, you know, we've been coming at it from a payment transformation perspective and how do we get outcomes-based models, you know, value-based care models, all these things in place. And I feel like lifestyle medicine is truly this catalyst of transformation because it's a tool to allow success, you know? So I'm really glad you joined.
Well, thank you for having me.
Yeah,
Thanks for being here.
Tell us about AFP and tell us about your work and lifestyle medicine and linkage, et cetera.
Sure. So the American Academy of Family Physicians is founded in 1947 as the American Academy of General Practice. We became AAFP in 1971 for a variety of reasons. Part of it was a transformational movement around the practice and the scope and community-based care and community health centers. Lots of things were happening in the United States and kind of the post-Medicare community-based care models were emerging, but family medicine kind of came out of that community-based movement to connect health and health professionals at the community level in response to kind of a very hospital-centric time period around Medicare, which still exists today in many ways. We represent 130,000 family physicians and medical residents across the country. We have a member, at least the last time we counted, in 95% of U.S. counties. They move around a little bit, but we have a very robust footprint across the country, and more likely than not, if there's people living in a community, there's probably a family physician somewhere nearby. We're an organization. We're a professional organization. We really do three things. We do member support. We have a very robust education apparatus, helping members be successful both in clinical practice, but also in their careers and profession. And then we're a big advocacy organization and doing all the work that you just talked about at the beginning. A little, you know, it was a little depressing to hear all the things that we got to work on. But,
sorry. Well, we're energized about it, so.
But, you know, it's a wonderful organization when, you know, people come to family medicine for all the right reasons. And, you know, it's just an opportunity. I really appreciate the opportunity to try to help make their world better so they can make other people's world better. And that's why I'm here at Lifestyle Medicine. And I think it's a continued pursuit.
Yeah. So you guys I'm always the yapper.
Yeah, now, what do you find the biggest barriers to moving it forward?
Just the concepts of primary care or lifestyle medicine.
Lifestyle medicine.
General. I think the barriers to the concepts of primary healthcare in the United States are the same for lifestyle medicine. It was the same as it was for health promotion, disease prevention, like all these concepts have faced the same headwinds in the United States. And it's because we have built a healthcare system from a benefits and financing perspective that is heavily focused on late stage intervention of disease. Right. We don't focus except for children, you know, and like there's this moment in time with children where we're very health and prevention focused. But by the time they reach, you know, young adolescence, we've moved away from that. But we're a healthcare system largely focused on late intervention of disease. And how do we not ignore people that need intervention to live a better life because of their disease state, but kind of pivot backwards earlier in the lifespan to start creating a more healthy population moving forward. And I say this all the time, it upsets people, but we're never going to solve our problems if we're trying to solve it at plus 50 years old.
Agreed.
I mean, we can't. I mean, that's like swimming against the strongest current.
Agreed.
You know, we're going to have to get way upstream and try to create healthier populations in the future, which in results, you know, could lower the economic pressure on our healthcare system and individuals and create a healthier population.
But it's interesting because I feel like we're coming into this magic moment where because we're spending $2 trillion, so it's kind of like the creep, right?
Yeah.
Healthcare used to be, to your point, like we built this I say sick care, which is a bit draconian in its statement, but people understand that, right? We built this system for keeping you alive, right? You're really sick, we treat you, we keep you alive, we treat you. And I think now with the rapid exponential growth of lifestyle disease, cardiometabolic disease syndrome, you know, we're spending $2 trillion on that. It's really largely bankrupting a lot of folks. And now all of a sudden people see that. And so I almost feel like we're at this magic moment where we don't even have to debate about quote unquote wellness and prevention, which I 100% agree with your point about we need to keep moving down. Is we have this huge opportunity in front of us. I mean, I've been shocked at the number of people that have said, even at late stage, in your 60s, right, that lifestyle medicine can truly reverse disease, and it's like, wait, we have this tool that we can put in our toolkit that could actually give an option to reverse disease, not just treat it, right? And as that takes hold and we show success, we could then say, okay, now we can keep moving down, right? We can use it as a tool to improve the health overall and not get to the point we've been getting to,
Right.
Well, yeah, we've collectively lost our minds. Like if we're, it's true.
No, you said this yesterday and it was so true.
And we have a common sense solution in front of us and we just need to advertise it. Like, but we're full delusional and now like we're awake. You know what I'm saying?
This was an epiphany. We actually have t-shirt ideas now.
It's so I actually agree with that. As those aren't the words I would have.
I just say
he just says it like
He says what
I would have chosen in my professional role. But I do think I think this concept of like we've lured ourselves into this like false optimism about like what actually is important in the healthcare system, and I think it's a real disconnect. You've made the point. It's a financial disconnect to individuals. It's a healthcare disconnect to individuals. Like people want to live healthier lives, and I mean if you engage them and you give physicians and care teams the resources to help people see a different alternative, more often than not they take that alternative. And the healthcare system isn't designed, and I made this comment yesterday in my talk here, the healthcare system is not designed from a benefit and financing structure for these conversations to take place. They actually disincentivize those conversations from taking place. And I think we have to align the outcomes we want with the care that we're asking people to provide. And I think right now the care that we're providing is aligned with all the wrong things in many respects.
But I do think, and that's why I say it's this moment, is I do actually get very optimistic when I look at all of the value-based payment models that we have accessible to us through both CMMI, through direct to employer, through commercial, ACE, all of those different Medicaid. I get hopeful because I think a lot of people have been uncomfortable to jump into those models because they've been doing chronic care management. Again, management. It's like, let's just manage the person. Let's try and just avoid a readmission, whatever. We're not reversing anything, right? We're not focusing on changing behavior. And I look at this and I say, wait a minute. If we could just deploy lifestyle medicine with cohorts of people, to your point, that actually want to get healthy. There are millions of people that do want to get healthy, and we give them the intervention to say, here, now we have an outcomes-based model to actually reinvest those dollars for a health system. They make a lot more margin on sharing 50% of the savings of a diabetic patient that just saved $30,000 in the year than they did on the margin of a stay.
Right.
You know what I'm saying? And I'm not talking about all of a sudden just like yanking all the inpatient admissions out. There's a real opportunity here to leverage the payment models that we have and align them with the practice of medicine using such simple tools as lifestyle medicine,
What if we're all healthy? What if we're all healthy?
Well, I mean, that's true, right? Like, I mean, that's the concept of just prolonging the onset of disease by a week, a month, a year. Like, I mean, just the impact that has at scale in a population like this. But I have two comments because, like, I think you're making an excellent point. We, for a long time, interventions or demonstration projects or innovation, particularly in primary care, were all designed to produce an outcome from someone other than the patient. So it was to save a hospital money, to save the employer money, to save the insurer money. There was never a system designed to help the patient be healthier and live a better life. And I think to CMMI's credit and to a lot of people in the marketplace, that has changed. People are becoming much more focused on this concept of whole person care, helping people live their best healthy life, no matter what state they may find themselves in at the time. So I think that conversation is changed a little bit, which gives us a new opportunity to align financing models and care models around, some of these new concepts. And I think that's why lifestyle medicine's having a moment. I think that's why you're seeing the appropriate, like, how does it get incorporated into more comprehensive care models so that it's not a niche, practice model. I think that's where at AAFP, lifestyle medicine should reemerge as a component of comprehensive primary care, right? Everybody should be doing this. And you should be doing it for children. These approaches to this concept of care do not have an age limit or anything else. I mean, these are just a good approach to better patient care.
Yeah, they don't have to be concierge. They don't have to be only for the rich. And I think that's it. Like, just we've lost our minds. Like, it's how to live healthy. It's like, you don't have to go buy some special implement or it's like, just sleep more and move your body and eat healthy. And it's like, just
and I
live a better life.
I haven't shared this
Too
one. But I've been
simple.
thinking all week. Like,
oh boy, wait. Tee it up.
This is the Roadrunner Wile E. Coyote kind of moment. Wile E. Coyote runs off the cliff and all of a sudden crashes down because guess what? It's unsustainable. The whole system, the way we're funding thing, everything.
Absolutely.
And we've hit that moment collectively as society.
Yeah, we're running. We're like really close.
Right. So, honey, I'll have the Acme
There's
pillow
an
ready for
anvil.
He's going
us
to be,
to...
Justin's underneath.
Is there going to be an anvil falling on us, or is there a pillow, an Acme pillow?
Yeah,
I don't
Acme
know.
pillow.
We're going to find out. Well, we know you have to get on with the day, and we know this is always a tight time frame. But we really appreciate you joining us.
Yeah, thanks for being here.
Thank you guys for having me. I mean, we got Roadrunner.
Yeah, we go everywhere. We're like...
And
like
feel free to jump in against the Roadrunner there. I didn't mean to stop the conversation.
No, it's...
We like to have
I wanted to
we like
give you
to
an
have fun.
out. I wanted to give you an out.
Meet.
So, thank you for having me.
Meet.
And you're welcome on for a full discussion
It's,
too.
I would actually welcome that. I will now. My mind, I'll be better prepared mentally
All right, yeah,
for what
yeah.
I'm getting into.
You think so, right?
But thank you for having me. Thanks for the opportunity to share a few thoughts, and I look forward to next time.
This
Yeah,
is not
it's been great.
Grandpa's podcast.
No, but we do have. A lot of people don't understand
have
the
fun and we
reverse
get
mullet.
serious.
It's party in the front, business in the back. But
Yeah.
you make it too boring, and people are like, "Yeah, I get enough of that at work every day." But you make it
That's
too
right.
silly, and it's not helpful. And so our goal is to hopefully kind of balance the two.
Weave it in.
Yeah.
So thank you.
And I don't want to be. I want to say one last thing.
Yeah,
I
please.
think I've been at this a long time. I think we are at an inflection point that is different than any other time that I can remember, and I think COVID created that in many respects.
Yeah.
I think it reoriented two essential kind of false truths that exist. One, it reoriented people around the fact that they do want to be healthy. I mean, you started to see kind of a refocus of the population on wanting to be healthy, and two, it reoriented the healthcare system that it wasn't actually doing a good job.
Yeah.
It was not, prepared to really meet the moment, and not the people inside the healthcare system, but
Absolutely.
the structure of the system itself was not really designed to meet that moment. And now it's how fast can we build? Can we stack bricks fast enough to build something different, or do we just kind of fall back into the routine?
Well, and it's interesting you say that because I was really at an inflection point myself in my career a year and a half ago. We all were. And lifestyle medicine to me is, I don't know, Justin will come up with a good analogy, or you seem like a good analogy person. I'm not. I feel like lifestyle medicine, maybe it's like the speed drying mortar that it's like you can take, we have certain elements in the care system that we built today, right, that can be deployed, like all of the primary care physicians that we have. But now all of a sudden we give them lifestyle medicine as a board certification on top and another way to practice medicine for the patients that want to reverse disease, right? And now all of a sudden it's like boom, 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 because you don't have to recreate the wheel. I guess that's it, right? It's like a tool to, super pump up what you already have or like retool it without rebuilding.
Yeah.
So-
And it's something
You electrify it.
Thank
Yeah.
you.
And they can.
I'm thinking of Grease. Electrify.
Yeah, electrified.
Sorry.
Just electrified.
John's like, really? I was trying to make a point, and now I'm seeing Olivia Newton-John.
Exactly, John Travolta. So I think the uniqueness is, I was thinking about this yesterday, for most physicians, particularly primary care physicians, I think people that are community-based physicians, the concept of lifestyle medicine is, probably very well oriented with their worldview of the type of care they wanted to provide when they went into medicine. So it's inviting them back to this concept of patient care that I think they probably saw at the beginning that's been taken away from them by a variety of factors.
Absolutely.
Over many years. And so there's a lot of optimism around it. And it's not it's not an EHR. It's not a digital health tool. Like, it's something they can do every single day with every single patient. And it has a kind of tactical feel to it, right? Like, they can touch it and feel it every day.
And it's a relationship. That's what we've heard over and over again, is the relationship that they can build with the simplicity of this.
Yeah.
Right? It's like back to basics. So anyways, all right.
Awesome. Well, thank you for your time.
Thank you.